Good afternoon, everyone, and welcome to our HSS webinar on managing osteoarthritis pain, or otherwise known as OA as well. I'm pleased to introduce our panelists this afternoon for an informative discussion on living with chronic OA pain and strategies to mitigate some of that discomfort. Joining us today are Dr. Ashley Austin. She is a HSS primary sports physician, and Jason Machowsky, who is a registered clinical exercise physiologist and dietitian. Thank you both for joining us. We all know how important it is to stay active. This is especially true for those living with osteoarthritis. So Dr. Austin, I will direct our first question to you. We want to exercise and we need to exercise, but how can you do it when OA pain keeps getting in the way?
Thank you for the introduction and welcome everyone. So I think OA is such an interesting topic, and I have a lot of patients in my clinic who come in asking me that very question, how do they stay active? How do they manage, the pain they're having? And I think part of, what I described to them is, everyone's goals are going to be just a little bit different in what they want to do. If it's getting back to a certain activity or maintaining a certain activity. And then everyone's OA pain is also a little bit different as well. So I think part of what, I try to do is cater a plan to them and kind of meet patients where they are. So some of the things that I offer patients just with management, staying moving, movement is medicine. So keeping moving, I'm rarely, if ever, recommending that patients stop exercising, and it's more of potentially changing how they're exercising. So I look at things like, how often are you exercising? What kind of support, like shoes or things like that are you using when you're exercising? I look at, what kind of surfaces are you exercising on? People with OA pain, as we know with joint forces, working out on concrete versus, working out on a treadmill or working out on grass or trail or a track that gives a little bit in the joints, all these things start to matter. It's really just kind of catering a plan to them. Some people, I talk to them about high impact versus low impact activities. So that's really a big focus in clinic as well. High impact activity are things like running, running, jogging, running, jumping, cutting, sometimes exercise classes, dancing. Some of those things can be higher impact. Whereas things like, I'm on the elliptical trainer, or I'm on a bike, or I'm, doing yoga or Pilates or some of these other things. So it's really just mixing in and matching, a series of different types of exercise for people really helps to give their joints a break in between some of the higher impacts. So alternating high and low impact exercise is also something I think is very important. But again, the key is staying active, continuing with movement. Movement helps with blood flow to the joints. It helps with healing and recovery after exercise. So very important.
Awesome. Jason, do you have any tips on how to progress with exercise safely?
Yeah, so actually a great quote that I heard years ago that always sticks with me is motion is lotion. I always like that phrase. Like motion is medicine. But yeah, like I think a big part of living and being active with OA is you still want to be active. And so taking on some tips would be, first, if you haven't been very active and you want to get started, start gradually. The body's awareness of what you've done in the past, that look back period is like 4 weeks or so, maybe 5. So you can say, oh, 3 years ago, I used to run 3 miles. Your body doesn't remember that right away. Ask yourself, what have you done the past month? That's your starting point. So again, a lot of people get into trouble because they try to do too much too soon, and then they aggravate a joint, and then it sets you back. When you start to decide what to do, you want to consider all aspects of fitness. You want to consider your mobility, your strength, your cardiorespiratory fitness, so heart, lungs, etc. As you start putting together like a little program for yourself, consider the intensity in which you're doing things, especially if it's new. You don't have to go all or nothing as far as intensity goes. You don't have to be going to failure and straining everything. If you can get on a 1 to 10 scale, 1 being no effort, sitting in bed, 10 maximum effort. If you can get to an effort level of 4 to 6, especially in the beginning, where you feel like you're doing something, but you're not like going crazy, that could be enough intensity to actually reap benefits and gains in what you're doing. So again, sometimes a little bit can go a long way. And that's also when I work with people, I really try to give like ranges. So let's say for strength training, I'll say we're going for 8 to 12 repetitions. On a day maybe where you're feeling more tired or not as good, go for the lower end. A day where you're feeling better, go for more. The key to that is it gives you a range of where you can go to kind of challenge yourself. And then if something gets very easy, we can always consider increasing load, but again, you don't have to rush it. And then the last piece is listen to your body over the next 24 hours. Sometimes inflammation can take time to kind of kick in. And so sometimes if we overdo it, we may not always feel it in the moment, but we might feel it the day after. The good thing is if you're very gradual with your progression, that kickback may be minor. It might be, oh, I'm a little sore in my joint. Okay, I did a little too much. I can dial it back versus trying to do too much too soon, really irritating something, and then you're laid up for another 4 or 6 weeks and lose all the gains you made. Last caveat is sometimes that feeling over the next 24 hours isn't always just the workout. Like there's a weather shift, especially in OA, like if the weather changes, high pressure systems can create some discomfort. If you, let's say, did a workout and then you decide to go for an extra long walk or go shopping and do extra lifting, it might not have been the workout, it might have been everything over the course of the day. So understanding what else you're doing too can be a cofactor as well.
I think that's a nice segue to remind us that there is a fine balance between exercising with pain and pushing yourself too far. How do you know when you are doing too much?
I get started with this one. I think, the rule that I think about and what Jason was alluding to is something like the next day rule, right? And this is what I give all of my patients. I talk to them about not making sure their pain isn't more than 3 out of 10 with any activity, right? So typically if it's getting past a mild discomfort into moderate or severe, you're probably doing something that's causing more damage. The next thing, and what patients sometimes are surprised by, which Jason mentioned, is the following day, they may be hurting and sore, limping or, having issues with what they did from the day prior. So really listening to your body and taking those cues. So, you shouldn't have any more than 3 out of 10 pain that day. The following day, you also should be, back to baseline, which is what you were before you exercised. No new swelling, no new inflammation, because really those inflammatory reactions can take a couple of days to really ramp up. And so you really need to then backtrack as to what you were doing. So again, gradual progression, really listen to your body. I think that's really a good way to keep from doing too much. I think also, again, coming back to everyone's OA pain is a little different. So, if we got x-rays on everyone and we saw the same amount of arthritis, people are going to behave very differently. Some people have, higher thresholds for activity and some people have lower thresholds. So I think it's important not to compare yourself to the next person and to really just make sure you're, individualizing your own plan, listening to your body. And again, just making sure you're recovering like you need to, but always staying active.
Sure. I think it's very important to just note that historically, we probably always just push through that pain because that's what we were taught or that's what we learned. But actually it could have some negative effects. So great examples from both of you. What if we did try to exercise on our own, but we're not sure what exercises to do or how to do them? Is physical therapy a good option? Maybe Dr. Austin, you could start with that one.
I think physical therapy is great. And the way that I sort of talk to patients about things is, ultimately, I see a wide variety of patients. Some patients are, being seen for like an overuse injury where they're needing to sort of like meet their body where it is, reset the process of what's going on and really work on building a foundation again. So I think our physical therapy colleagues are a great complement. And I know certainly I wouldn't have a practice without having them, as well as our exercise physiologist colleagues as well. But they really do cater a plan and tailor a plan and individualize a plan for each patient. So based on where they're having symptoms, how, what types of things they want to get back to doing, how their individual movements, are relate to what they want to do. I think physical therapists can work on strengthening. They can work on, mechanics of how they're doing activities. Sometimes it's not a matter of, I'm weak in my muscles. It may just be that you're not activating the right muscle groups when you're trying to support your joints when you're doing exercise. So a lot of it can just be, muscle retraining. As we get older, we know that our muscle does, start turning into fat cells, right? We know that we have less muscle as we age. And so it's even more important, I tell patients, hey, when you're 20 years old, you have, let's say 10 muscles that are supporting your joints and they're all working exactly the way they need to work. And as we age, some of those muscles may tire out. Some of them may need a reactivation. So I think physical therapy is great for sort of reactivating muscles that may be fatigued or may not be dialed into what you want to do. And then also building and making sure you're maintaining strength. There's definitely a real importance to just general strengthening for injury prevention versus, just kind of secondarily saying, okay, I'm having pain in a joint, now I'm doing work. So I think there's an injury prevention aspect that's important as well.
Do you have a time frame that you generally like to tell your patients to try PT for? Is there typically indicators that we say it's been X amount of time, maybe this isn't working for you?
So I think physical therapy, what I've found for most of my patients, if they're diligently doing physical therapy, and that means, going into visits. So, I mean, with all of our schedules are busy. So 1 to 2 times a week is usually very reasonable to get somebody in. But I think where the real benefit happens, or where the real progress happens, is the homework. So what they're doing when they leave the physical therapy session, this is 30 minutes to an hour of work that you're doing, but you have to then translate that into your life, carry it over, do those exercises. If you're doing that diligently for a good 4 to 6 weeks and you're not seeing any benefit whatsoever, and sometimes you don't get all of the benefit, but you are still moving on that upward trajectory. That's what I'm checking in with patients for around that time. Are they moving in the right direction? If they're stagnant, if they've hit a plateau where they progress in the first couple of weeks and then, they're not really making any headway, then I'm having a conversation about, next modalities for management. But if they're making clear progress, sometimes I'll even put a new prescription in for PT. Patients always say, when am I done with PT? I think, when you stop making that forward progress, if you plateau, and, if you've gotten good enough to where you're not having an issue anymore, this may just mean you convert to a home program that you're doing longitudinally for strength work and training and injury prevention. So that's generally what I tell my patients.
And I think if patients just work with their physicians and physical therapists, they can get to that point that hopefully they start to integrate this practice and exercise into their everyday lives. And just to mention what Claudia said before, we do have a lot of community education outreach classes on our website that are safe for osteoarthritis. So if you're looking for that adjunct with the physical therapy that you're in, it is a great way to implement some more work. Jason, is physical therapy the only option? Is there a difference between PT, exercise physiology, personal trainers?
Yeah, so I mean, to kind of piggyback on what Dr. Austin was saying, is, like a lot of times, like I think, PT is really good for someone where your OA is getting in the way of your life, right? Like you can't get around where you want to because your knee hurts, or you can't reach a shelf because your shoulder hurts. Like that, your activity today living and your daily functioning is being significantly negatively impacted because of this pain. PT is your go-to to say, okay, we got to figure out why that's happening. Is it because something's tight? Is it because something is weak? Is it something not moving right mechanically? And we got to get that covered. Ideally over a series of weeks or months, that gets better. And then you get back to baseline and say, okay, I'm good. So you have a couple of options there, right? You can say, okay, I'm good doing what I'm doing. And I just have my home exercise program, because the thing we always say is the things that get you better, keep you better. So the thing you don't want to do is do all this hard work over a bunch of months and then stop doing all the exercises that you just did to get you better. You need to have that home exercise program and keep it up. If you say, okay, this is great, but I want to do more. I want to get stronger. I want to be more resilient. I want to do something new, a new activity. That's where, good training. Until we talk about exercise physiology versus personal trainers, you want to be working with someone in the strength and conditioning or training world that has an understanding of kinesiology and exercise science, so a degree or something where you actually have experience understanding the nature of orthopedics and movement and injury states and things like that. Because the whole goal is, in the pursuit of trying to get better, you don't want to get hurt. Unfortunately, you hear too many stories of people trying to push, and then they end up back to where they started or worse. So the whole idea of moving forward and then working with an exercise physiologist, let's say at HSS or somewhere else in the gym, is you say, okay, I am at my baseline, I am well, I am not in significant pain, I can do what I need to do, but I want to get better and I want to do it methodically and safely. That's where a good, clinical exercise physiologist can help you take those next steps forward in a holistic way, where we're looking at you not just saying, okay, I have knee OA or I have shoulder OA. That can be true. You do have knee OA, but your goal is, I want to be able to do a sport more. I want to be able to dance more. I want to have a healthier heart. It's how do you take a more holistic goal, acknowledge that you might have OA in places, and still achieve it safely.
Right. Do you believe that diet and nutrition play a role in managing our pain?
Yeah, so as a dietitian as well, I've spent many years in school to get all these different things. So yeah, as a dietitian, we talk about, nutrition can play a role in help managing pain. And so from a high level perspective, a lot of the basics are out there. So eating your fruits and vegetables, having, omega-3 fatty acids, your healthy fats throughout the day, eating adequate calories to allow your body to heal and recover. So being chronically underfueled can sometimes lead to breakdown because your body isn't getting the energy it needs. Adequate protein, those are the building blocks of your muscles. So if you're putting in the effort to do the work to load your muscles, you want to give them the energy for it. So again, a lot of the basics go a long way in just giving yourself a good space. And then I don't want to delve too deep because you can all do a whole talk on like food sensitivities and food allergies. But the idea is, yes, certain people are sensitive to certain types of foods, and the common ones you hear are like gluten and dairy and things like that. But it's not a one size fits all deal. You got to figure out if you are the person that's sensitive to it. There's different ways to figure it out. And if you are, then yes, you can take out foods that you're sensitive to. But again, that's very individual.
Any supplements that we can add, whether they're over the counter or possibly prescribed?
Supplementation is a tricky thing as far as, I'll just kind of handle over the counter stuff. So there's some stuff out there that has some potential promise, but it's funny, the more supplements that have a lot more research behind them show that they're like less definitively great. So if you hear like the ones that are classically studies are the chondroitin and the glucosamine for the knees, and the research shows that it kind of works for some people and not for others. There's things like MSM, type 2 undenatured collagen, avocado soybean unsupplentifiables. There is like a lot of stuff out there. The thing about it is it's very individual. There isn't this like robust signal where like everyone will benefit from it. Mm-hmm. So first thing you want to do is make sure you talk to someone qualified to help you sift through A, is it something that could possibly work for you? And then B, do you have any other food or drug interaction? So you don't want to be taking a bunch of supplements that you may have, a drug interaction with and not be aware of. So again, there's nothing saying there's no smoking gun saying there's definitely the thing to take. Some people swear by turmeric, some people swear by other things. So there's stuff out there, but again, it's individual in nature, and you kind of want to be guided with it.
I think that's a really important top point that you did make. Just because they are over the counter, just making sure that they are safe to take with other medications that you are taking. So making sure that the whole means is really justifying what you're doing.
Like one really quick example, a really quick example is like turmeric. A lot of people take it for inflammation. It actually can increase for people who have history of kidney stones. It can increase your risk of kidney stones. So again, that's just one quick example. But again, that's one of the questions I ask people before I ever recommend something like a turmeric.
Dr. Austin, so if we maintain a healthy weight, diet, and active lifestyle, but the patient's still in pain, are there some home treatments we can try without medications?
Definitely. So I think, again, this is a multimodal sort of, kind of a lot of different pathways to go by to sort of manage something as complex as osteoarthritis. So for at home, things that are not medicine related, I will offer, different braces for people, right? So there are, a variety of assistive devices. It depends on where people are and their mobility level, but bracing, there are certain braces that can offload areas of the joint that have arthritis, specifically talking about the knee. Other things like, doing, we talked a little bit earlier about shoe wear, but things like making sure they have supportive shoes that are supporting their joints the way they need to be. There are patients that have, are to the point with their osteoarthritis where they have, they're using canes or things like that, right? And sometimes there is a stigma to using a cane, and people will, would rather just be in pain than have a little bit of offloading of a joint. And so sometimes I recommend things like hiking poles, which are things that sometimes people don't think about, but they're kind of the fashionable cane, right? If you have a hiking pole, then suddenly, it's pretty cool. And I'm off going on a hike maybe, or maybe I need this for an assistive device, but so there's like creative ways like that people can help. So I think assistive devices are a big way to help people as well. I think organization of home and making it easier to get things. So, if you're having a lot of shoulder pain, and this could be you or someone, a relative or a friend that's making adjustments to where things are in your home. So sometimes people don't think about that, but really like getting rid of fall risk, like making sure there aren't rugs in places where, you tripped. If you need more assistance with, standing in bathroom, using, medical devices like, having a shower chair and things like that. So there are companies and programs that are available for people to go into their home and figure out ways to help optimize their day-to-day activities. So I think that's really important as well. And then utilizing people to help you, if it's causing you a lot of trouble, leaving the house, kind of planning in a way that you can, utilize home deliveries and other ways where maybe you want to walk your 4 miles a day, but you don't want to spend, 2 of those miles walking through the grocery store. Well, you can walk 4 miles and then maybe you have your groceries delivered. So there's a lot of ways that you can sort of incorporate offloading the joints and that recovery that's necessary for continuing to live with osteoarthritis pain that I think is very important.
Those are great tips. But what if those home treatments aren't still working? Any medications that we can recommend?
Absolutely. So medications, another way to sort of target osteoarthritis pain. One type of medicine, or like oral, what we call oral medicines or medicines by mouth. Those could be things like Tylenol, anti-inflammatories, like ibuprofen. So acetaminophen is Tylenol, ibuprofen, naproxen, that's another type of anti-inflammatory. So something that's targeting the inflammation to try to get your body to hit a reset. These medicines are not changing the arthritis in your respective joint, but they are decreasing the inflammation that is associated. And the way I see osteoarthritis is it's something that's developed over many years. And so when you think about combating it, you really are just trying to reset that area so that your body can compensate appropriately, and then you can, build to continue to do the things you want to do. So I think oral medications, topical medicines, there are topical, lidocaine medicines, there are topical anti-inflammatories that are out there, like diclofenac gel and things like that can go right over the area where you're having pain, and sort of, especially for people with underlying heart, lung, kidney issues, it can be very helpful for them to use a medicine that doesn't go into their whole system, but something that's just targeted to one area. I think ice and heat. Sometimes people ask me what's better. I like ice for recovery. So I've, done an exercise, now I'm recovering. I like heat to sort of warm you up before doing an exercise. So those types of things are important as well. I consider those sort of medicines, if you will. And then the other types of medicines are things like, injections, right? And these are things that your physician can offer you. And those are things like cortisone injections. That is basically a targeted way to approach inflammation. Rather than taking a pill that causes decreased inflammation, we're kind of putting it right into the joint area. So that's a cortisone. There are also platelet injections, or PRP, which are regenerative medicine that kind of go in the joint and help to sort of preserve the cartilage that you have there. So all those things. I think the other type of injection we have are like gel injections or hyaluronic acid injections, which go in, they help with inflammation, but they also help to cushion the joint. It's almost like an oil change, this gel sits in between those areas of rough cartilage and really help to kind of make your joint movement more smooth, and to hitch a little bit less, and also helps you stay active. So those are the types of things when I think about medication.
I think, and hitting those non-surgical procedures or injections that we can do. I think the most important thing that we're targeting here is that everything essentially should be done in conjunction. You take these over-the-counter medications to try to reduce the inflammation. Maybe you need to jump into the prescribed naproxen or diclofenac, something that is a bit stronger to get you through, in order to make PT work, in order to get you stronger, in conjunction with that exercise and diet. So it's the full picture. So we did discuss all of these ways, and unfortunately, if the pain is still not manageable, when do we recommend seeking out surgery?
It's another great question, and I think I totally agree. These are all happening in conjunction. One single therapy is probably not going to manage your osteoarthritis pain effectively, and so when I think about when we're seeking surgery, typically we have failed our conservative management. So the things that we throw into conservative management are things like, we have taken either prescription medications or done injections to try to decrease the inflammation around a joint. And typically these things, your body potentially is not responding to those things. We've also done things like physical therapy to try to help with strengthening around for better support of the joint. A lot of times, if people don't get their pain better and their inflammation isn't down, they're not very effective at physical therapy because they're usually guarding that area pretty heavily. So the nice thing about those things is it's resetting that process and allowing you to build a foundation. But if those things still aren't working, and we've done bracing, we've done assisted devices, we've done shoe wear support, we've done, all of these things, then typically we are having a conversation about, if there's a surgical option for management. I would hesitate for anybody to jump straight to surgery without having tried those modalities, because a lot of times along that pathway, people do find something that sticks and that does, help them with not having a surgery. Certainly surgery comes with its own set of complications, and you'd want to know when you're having surgery that, you've tried all conservative things. And I'd say any surgeon would say that as well. And so the other things outside of failing conservative management, how I would recommend surgery is something like, you're now getting pain in other joints that are above and below where your problem is. So, for shoulder, I see people start getting neck pain, or they start getting back pain with how their posture is, how they're supporting themselves throughout the day, they're compensating. So when that compensation starts to happen, and for knee pain or hip pain, it may be looking like I now have back pain, or I may have foot and ankle pain. So pain above and below the joint of where, your initial problem started, that tells me that the body is not appropriately compensating for what's happening. And that to me means that, addressing it with surgery is probably the best way to go before things worsen, because ultimately, if we were to look at someone who has knee OA, they probably have a little bit of OA in the other knee as well, but the other knee may not even be a problem until they start relying on the other knee so much because they've let it get out of hand. So I think it's addressing it at the appropriate time frame and not letting it get too far is very important for surgical evaluation.
Absolutely. And I think all those things are really important things that I see with our patients that we used to see as well, that everything along your journey matters. Everything that you've been through, timing of how long you've been through, what Dr. Austin was alluding to, pain in other areas, your body will know when it's time, and it'll tell itself. So that's what we're there to help you with, to kind of guide you to that point. We will jump over now into our audience questions, unless Jason and Dr. Austin had any last minute things they wanted to add to the questions that we brought up. And if not, I will jump right into our audience questions. And maybe I'll start with this one, since we just left off with a similar topic. Is it helpful to get those injections preventatively? Example, like the hyaluronic acid gels. And when is it the right time to consider them?
So I think the difficulty with doing these preventatively is that if we were to do an X-ray on most people over a certain age, they're going to have some wear and tear in their joints, right? So this could be the hip joint, this could be the knee joint, shoulder joint, but whether those joints needed intervention or not, it isn't necessarily true. So for one person, they could have, severe arthritis and not have any pain whatsoever. And somebody else could have just a small amount of arthritis and have pain. So I think it really is important to treat symptoms and to be diligent about it. With any injection, there's a risk of infection, though very low. And there's a risk for a complication like, you have an allergy to a, injection there. Injections are not without a small risk. And so to me, the preventative aspect of that, I probably wouldn't vote for as much, just because we really don't know if that joint's going to become symptomatic or not. So just by finding it on X-ray doesn't mean we treat it. And I'm really big on treating the patient. So if you're asymptomatic, no symptoms, I generally will not recommend preventative injections. You may or may not need them. To caveat, to segue in, I would also say, it's much harder to treat people when they're 10 out of 10 pain coming into your clinic, right? So there is a real sweet spot to where this is clearly bothering you in your activities of daily living. You're making adjustments for it, but it's not so bad to where the anti-inflammatory interventions that we have are not helpful for it.
Jason, are there any forbidden foods that affect OA negatively?
Are there any what foods?
Forbidden foods, things that we should stay away from.
Oh, that's a good question. I think the ones that tend to be more associated with increased inflammation are the refined sugars and sweets and starches, kind of all this. I say it's like kind of grandma's advice, like all the things that are junky. You definitely want to say, okay, I don't want to have too much. Does it mean you can never have a cookie again or a piece of cake? No. It's more like if this is the bulk of your diet, it's probably not helping you. There is some interesting research where they had people, like young adults, drink like 20-ounce soda a day every day, and they saw that like their C-reactive protein went up and other aspects of inflammation went up. It was just like 20-ounce soda a day for like 3 weeks. It was interesting to see. Like really processed meat sometimes, like kind of like the heavily processed deli meats and bacon and stuff like that. Again, large amounts of it may not be great. Large amounts of alcohol may not be great. So those are kind of the ones where, again, like everything in moderation for the most part, but if these are things that you're really eating a lot of or it's forming a big part of your diet, and you're dealing with chronic pain, it could be worth kind of cutting back and seeing if it's.
Another question that came in from the audience. I just read about genicular artery embolization. Is this a viable option for someone with knee OA who is moving but has pain and is not nearly ready for a joint replacement?
So genicular, and it would be the genicular nerves that you're embolizing. And these are nerves that we know are situated in and around the knee joint. And we know that a lot of times when the knee joint has been inflamed for a long period of time, the nearby nerves also become inflamed. So that's sometimes why people describe pain kind of moving down their leg from the knee joint or moving up their leg from the knee joint. So this is inflamed nerves. It is a viable option for people that aren't, ready for surgery. I would caution people to say it is very much a procedure for pain and not necessarily for any instability or catching, popping, locking, clicking. These are mechanical symptoms that patients will describe. It can't change those symptoms, but it can change pain. And so I find the best candidates for something like this is people that, number one, as mentioned, aren't ready for surgery, people that are not candidates for surgery. There are, BMI requirements for surgery. There are risks of anesthesia for people with underlying heart, lung, issues that they can't, or people that are on blood thinners that can't have a knee replacement surgery if they can't stop their blood thinners. So those patients are great candidates for something like genicular nerve ablation. In some cases, people have had a joint replacement, and after the joint replacement, they're still having some pain, and sometimes that's residual nerve pain. So that's another indication for it is post replacement surgery. Typically, people are doing it. You have to be at least a year out, but that's another way that can be used. So a lot of different applications for genicular nerve ablation.
Is osteoarthritis reversible?
Osteoarthritis, from what we know, is not a reversible process. It tends to be a progressive and degenerative process over time. There are new and upcoming things like stem cell, which people have sometimes heard of, which we're not doing in our practice here. There's still a lot of research that has to happen to know if cartilage can be regenerated. But from what we know right now, we're not able to do that. Things like platelet injections, which is something that I do in my practice, works more to preserve the cartilage that's remaining. It has a small regenerative effect that we're still learning more about, but nothing substantial. It really is just kind of stabilizing the knee joint where it is in that snapshot of time.
One thing is interesting. I always look at some of these these kind of group studies, cross-sectional studies, where they imaged, let's say, like 500 shoulders of people in their 60s, and a huge percentage of them had deterioration, fraying, like breakdown in the joint, like just like a car breaks down over time. Unfortunately, we are mechanical bodies. This happened. But what they found was that there were tons of people who had this quote unquote like breakdown in the joint who had no pain and no limitations. And I think that really speaks to the possibility of maintaining function through strength, through capacity, through staying active. What I typically see, especially in my practice, is that when you start to lose that strength and lose that muscle, it becomes harder because activities of daily living start to cross that threshold of the capacity for your body to bear it, right? So if you can't go through your day doing activities without pain, it's a lot harder to strengthen yourself back beyond that versus if you've been generally active your entire life, you've managed, you haven't overdone it, you haven't underdone it, you've just listened to your body and you've stayed active and strong. You can continue to do a lot of things for a very long time, even if your joints don't look, quote unquote, look great.
Absolutely. if Advil and Tylenol are helping manage my pain, is it okay and safe to take these medications continuously?
So I think for, when I think about patients taking medication continuously, I think about, what's likely happening is that we've hit each of the steps of the ways that, their arthritis can be managed, and we're kind of like checking those boxes and they're still not getting better. So, in patients that are continuously taking it for pain, that's why we try things like injections, where we can prevent them from having to take oral medications. There are some long-term risks to taking things like, Tylenol and taking things like ibuprofen. Ibuprofen, like anti-inflammatories, we know that over time they can cause issues with the GI system, GI ulcers, GI bleeds. We know that they can put you at risk for heart problems, heart attacks, other things like that when used long-term. The other thing to think about is long-term is usually, when I think about prescribing for a patient, I'm generally not doing it for more than a couple of weeks at a time. So I think it's very reasonable to say, I had a flare-up of my symptoms. Okay, I'm taking this for a week or two. And then after that, if you're finding that you're still needing to, take medication, then you really think about, what should be the next step in your management, because that shouldn't be the sort of ending phase of your management, is taking medicine. And things like ibuprofen or work on inflammation. Things like Tylenol is more for pain when we're talking about the joint. But I think that's really important, is, the long-term effect of taking those. Kidneys as well can be affected with anti-inflammatories. So should be very careful with taking those long-term.
Well, unfortunately, we're close to the end of our time here. I want to thank Jason and Dr. Austin for all of their expertise. There's two catchphrases that they said in the very beginning that I'm already going to steal because I love them. Movement is medicine and motion is lotion. I think those are really important for people to understand and realize, and understand each situation. Although it could be a daunting diagnosis to hear you have osteoarthritis, how do I move forward? There are modalities, there are things that we could do before surgery has to come into the picture. And I think just sustaining this sort of lifestyle is a positive thing, these healthy things, physical therapy, exercising, diet. So really there are hopeful things out there that we could do. And to our audience, thank you for joining. HSS values your feedback. So please let us know how you enjoyed the program by responding to the survey that's in the chat, and how we can improve these future programs for your benefit. That's all we do have time for today. Thank you for tuning in. And if you do have any further questions or like to learn more about HSS, please visit hss.edu. Everyone have a great day.